Broadcasting from the historic Hayburn building here in downtown Louisville, it's Single Payer Radio. The show is a project of Kentuckians for Single Payer Radio, for Single Payer Healthcare, and we're an affiliate of the Kentucky chapter of Physicians for a National Health Program. We have this program because of the current fragmented care system that we have, costs twice as much as in other developed countries, and delivers worse outcomes. Tens of thousands of Americans die unnecessarily each year because they can't access care. Over 100 million Americans carry medical debt, setting themselves up for bankruptcy due to this system. Kentuckians for Single Payer Healthcare works to stop the Wall Street takeover of Medicare, and we oppose the privatization of the VA system. Learn more about Kentuckians for Single Payer Healthcare at kyhealthcare.org. Everybody in, nobody out. Views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard on WFMP 106.5 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal, you can live stream us. Go to forwardradio.org. Just click on the live stream. If you miss a show, you can go to forwardradio.org and go to our archives, forwardradio.org/single payer radio. WFMP is an all-volunteer station. We rely on the community for your ideas and our funding. And speaking of funding, I want to thank everyone who pitched in for our spring membership and 6 years going on the air celebration. Thanks so much. Our goal was $4,000. We raised $6,500. Great job, everyone. Doctors Mike Flynn and Gene Shively are back in the studio. Mike, I'm going to turn it to you.
This is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make during this program represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery.
This is Eugene Shively. I'm a retired rural surgeon from Campbellsville, Kentucky. Any comments that I make are those of mine and not Taylor Regional Hospital or the University of Louisville Department of Surgery.
So Gene and I have just finished 3 programs on the U.S. healthcare industry, focused on extracting profit from healthcare activities, as opposed to a healthcare system present in most of the other first world countries, focused on providing healthcare to its citizens. So today's program topic is Medicare for All, single payer health insurance. We have 2 special guests who are very knowledgeable about this, and hopefully we will have a good understanding of our listeners at the end of the program. So our 2 guests include Kay Tillow. Kay is the chairperson of the Louisville chapter of Kentuckians for Single Payer, and Garrett Adams, past president of Physicians for a National Health Program. Kay and Garrett, thank you very much and welcome. We're looking forward to this discussion. As we have done in the past with our guests, we're going to give you both an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And then the conversation will begin with Gene asking you the first question. So, Kay, ladies first, the floor is yours.
Well, thank you, Mike and Gene and Mark. I'm really glad to have an opportunity to be on Single Payer Radio. I appreciate the fact that the 3 of you make it go and produce shows every week. And I'm really happy to talk about single payer healthcare because it's the thing that I spend more time on these days, in the hope that one day our nation will have a program that will allow everyone to get the kind of care that they deserve and that our great country has the ability to deliver. We just don't have a healthcare system that is able to deliver it. And the basic problem is that our healthcare system is based on profit. There are for-profit health insurance companies that basically dominate the whole system. And that domination causes all the things that are bad within the system. It puts a burden onto the physicians, forcing them to get pre-authorization prior to carrying out what they think is the correct treatment for a patient. So it's frustrating our professional caregivers in a way that is destroying their ability to really perform professionally. For patients, it's leaving them many cases without care. You know, we went from a situation with before the Affordable Care Act, where our biggest problem seemed to be the lack of insurance by about 50 million people. We got some more of those covered with the Affordable Care Act, but we increased underinsurance. We increased the number of people who, while nominally they have insurance, they can't afford their care. So the system just isn't working. And you can see it by, well, a couple of things. One, that our care costs per capita about double what it does in the other industrialized countries. And, you know, that would be fine if we got twice as good a care. We might say as a nation, well, this is good. We'll spend more money. We'll have better care. We'll have healthier people. But the opposite is the truth. The truth is that even though we spend double, our outcomes are worse. And our infant mortality is not good. Our longevity, our life expectancy is not good and getting worse. That's what the terrible thing is. Over the last few years, it's gotten quite a bit worse. I think we're about maybe 4 years of life expectancy behind Italy and some of the other countries. So all of this spending is not producing a better system. And we have extreme stress in the nation for people worried they can't change jobs. You know, how much is the copay going to be? People going without care, without cancer treatment, because they are concerned about the cost and they don't have the money. So we don't have a humane system. And that really is the reason we have to go to a single payer system. There is nothing short of that will solve this problem of controlling the costs and yet expanding the care to all of our people. And I just want to quote something from Marcia Angel, because it struck me as kind of a marker to tell what's happening. She was the former editor of the New England Journal of Medicine. She's a strong single payer advocate. And when, you know, Physicians for a National Health Program announced their plan, it was Marcia Angel who spoke to explain it. And she says that our problem is that within the system as it now functions, you cannot improve or expand care without increasing the cost. And you cannot cut the costs without cutting care. That's the system that we're in. You can't do what has to be done. And that's why we have to make the jump to a system that removes the profits, removes that 30% of that administrative cost that goes into making profit, and then allows us to do both of those things: control the costs, expand the care, cover all of the people in the country, and take away the copays and deductibles, which are really insurance company barriers that are keeping people from getting the care. Allow physicians to function according to what they have learned in their profession and in their experience, not according to what they can get the insurance company to agree to. and cover everybody, and we'll be a better nation when we know that every single person is covered. And quite frankly, it's in everybody's interest to do this. If your kids have coverage and are riding on a bus with the kids who don't, they're going to get the diseases that the others have. It's in the interest of all of us to make the whole nation as healthy as we can and to uplift everyone that we can and to provide the best care in the world, which we have the ability to do. We just don't have the system to do it.
All right, thanks. Okay, Garrett, your turn.
I appreciate the opportunity to be with you, Mike, and Eugene, and Kay Tillow. A spokesperson not only in Louisville, Kentucky, but nationally for publicly funded national health insurance. She has been a leader, recognized in all of our states as a person who really has her hand on the wheel and has been an inspiration in working for change, as you can tell from what she's just said. And Mike, I think you hit the nail on the head when you said called a United States healthcare industry as opposed to other countries have a healthcare system. This industrialization of my profession makes me angry. And I get even more angry when I listen to Kay describe the poor performance of but it's not a health system, so I can't even say it's a health system. It's just a mess, and we don't deserve this. What's wrong with Americans that we can't straighten it out? And I think it's exactly what Kay said. It's the profiteering, which is completely out of hand. Dwight Eisenhower talked about the military-industrial complex, and recently someone has taken those words and applied them to this industry, and we talk about the medical-industrial complex, which is just sickening. There's a, let's see if I can think of, what's that pharmaceutical, McKesson. The CEO at McKesson, several years ago, I happened to have an opportunity. I looked this report from Forbes magazine about the take-home pay that certain executives got, and the take-home for the president, CEO of McKesson at that time was $148 million, if you can imagine. And there today it's even more. Kay was just telling me about the take-home of another member of the medical industrial complex, Health Corporation of America, HCA. And it was, again, a multi-million-dollar take-home pay. And we see that over and over again. And we'll not get what we deserve as a country until we can get away from all the profiteering. And it's getting worse with the recent privatization. So what is a single-payer healthcare? I remember once, many years ago, I had an opportunity to speak on public radio, and this was back, I think, about 2008. And I thought about a single payer, I said to the host that it doesn't mean that you're not married. It's what it means is that there will be one person, one institution that is responsible for payment of medical expenses. The way this is going to work when we get it is there will be a trust fund, a Medicare trust fund that will group all of the current funding for Medicare, Medicaid, child funds, children funds that are in the government, and all of these funds into one. Plus, initially, there will be Gene wanted to know, what about an increase in taxes? Yes. Early on, there will be a slight to moderate increase in taxes until the fund gets completely established. And then all of the money that how are we going to pay for this is by recouping the money that you'll have more in your pocket at the end of the day, in spite of this slight increase in tax, because it more than offsets what you're paying now. So not only is there that financial benefit, but there's the benefit of having health care, of being able to choose your doctor, go to whatever doctor you want to. Delivery of health care, as envisioned by the Physicians for a National Health Program, is that it will remain private in those cases that are private. But you would have free choice of doctor. You're not going to be limited by that, and free choice of hospital. And the only difference is that the payment comes from the trust fund. So there's no payment at the door. There'd be no deductibles, no need to pay upfront when you go. You not get a bill. The bill goes to the government, goes to the trust fund. And so the patient, the sick person, just has to work with the doctor, and the doctor just has to work with the person, and the government pays, the trust fund pays the bill. So there's no argument over fees. There's no prevention of going back to the doctor for another visit. I have a friend in Tennessee where this has been an acute problem, who more than one friend actually that this has happened to, where they had an initial surgery, but they didn't finish paying for that surgery, but they needed another follow-up surgery. This particular one was a man that had cancer of his bladder, and surgeon wouldn't see him because he didn't finish his bill. So, and those things would not happen if we have a single payer plan. Now, I may have left out a few of the essentials. I'd be happy for Kay to fill those in, or one of these good surgeons. So we got a couple of good surgeons running this show today.
All right, we're gonna let the program begin. Jane's gonna start off with fire the first round across your bows, and we'll see where we go from there.
Is it possible to have a single payer system that's regulated by the federal government, but is not run by a trust fund, or the money comes from the federal government? It could come like it does in Germany, where patient pays so much and the employer pays so much, and they go to profit insurance company. Is that possible? Because there seems to be so much hostility when you even mention the word socialized medicine. Even though everybody is hostile to that, they don't realize that we are already socialized. For example, the hospital that I work at, over 70% of the patients are Medicare and Medicaid. And I just visited a cousin down in Florida who is administrator of 2 hospitals, and it's in north of Orlando where the Village is, which is all people over age 65, and 80% of his patients were Medicare. But I guess my question is it possible that we can run a single payer system where everyone's covered, where the government regulates it, but the money could be distributed through the payroll, similar to a payroll tax?
Why don't you both comment on that? Kay, you can go first, and then Garrett.
Okay. Well, you ask complex questions, Jean. So let me just try to deal with a piece of it. The German system, while better than ours, is the least efficient of the European systems, partly because it's not really a full single payer system. It works better than ours, basically because it's so tightly regulated that the insurance companies are not allowed to profit from healthcare, and they profit in other areas. But the efficiency of the system is not good, and it would be just as difficult for us to go to a German type system as it would to go to a real full single payer system. The insurance industry would fight it just as hard because it would squeeze out their profits. So it doesn't seem to me to make any sense to promote it as the ideal, since it is less efficient. It was in place a long time ago. You know, we've gone far beyond that with what the insurance companies have, and they would fight just as hard to have that tightly regulated system as they would a single payer system. So it seems to me it doesn't make any sense to go to a German style system for us. The other thing is that single payer isn't a socialized system. A socialized system is like they have in the UK, where the physicians and all of the healthcare employees actually work for the public institution, that the public service, and the hospitals, et cetera, are owned by the public service. Single payer allows physicians to have private practices, et cetera, and simply controls the bad things by becoming the only payer, and strips out the profit-making insurance companies, and it strips out the for-profit hospitals as well, so that we get the worst things out of the system and allow people to actually get the care.
Garrett, your thoughts?
Well, I think we can get the benefits of the other programs. For example, the French is one that I would that appeals to me, and that they have what they call a carte vitale. But we would have the same thing. When you're born, if you, according to our plan or potential plan, which has been formulated in a couple of bills, and the current bill has had very good success in the Congress so far, because you would have a Medicare card, and the French, for example, this carte vitale can be used at any place in France, and it keeps all of your medical records. So you go to any doctor any doctor, wherever you are, and they know, they flip that card into the reader and they know your whole history. And not only that, but the payment will be initiated right there. So it could be simplified so much. And that's what we would get at birth. You would get this card, or if you're a resident of the United States, then you are entitled to all payment of all services. And if think about how much better we would have been prepared for the COVID pandemic if we had had that system set up. And all of the people that have died because they couldn't afford care, and it's criminal. And I keep coming back to the fact that this is and I'm going to try to not use profanity, but I'll let Mike and Jean do that when necessary. But I really get angry to think about what happens with people that can't get care because they can't afford it. We were faced with that with a community in Bershaw Springs, Tennessee, on the Cumberland Plateau that I'm familiar with. And the people in the community set up their own free clinic. And we're seeing there some 2,500 patients a year who have otherwise no way to pay for their care. And the community is funding this clinic as a free clinic. So I'd like to see something like the French system. Of course, the Canadian system is good too.
Well, let me emphasize something that you both said, and then ask your question before I'm going to do that. Mark gets very nervous if we use strong language, so we're going to try to avoid that. We've had a guest speaker on here that got pretty good for a while. Anyhow, the single payer healthcare or Medicare for all is an insurance program. It is not a healthcare system. I mean, Kay, you've just emphasized that, and Garrett, you did as well. In my experience discussing these issues with some of my colleagues, they often don't understand that. I mean, they're looking at something like Great Britain, where they run everything from the pharmacy, the hospitals, and physician practices. So that's I just want to emphasize that because I think it's an important factor for our listeners. But let me ask you both, where do the for-profit health insurance companies fit into a future system? Now, they do exist in Britain. It's a small part of the market, but they're there. We had Ted Young, surgeon from Hamilton, Ontario, on recently, and they exist up there. They exist in Australia and New Zealand. So they're around. They haven't gone away in those other programs. Now, with Medicare for all in this country, do you both envision them, just going away or losing their market dominance? And so let me
Well,
your views about that.
A single payer system to work has to take all of the coverage for all medically necessary care. That would include dental, eyeglasses, etc., long-term care, mental health, everything. So and the private insurers would be excluded from covering what is covered under the system. So they could cover cosmetic surgery that's not essential. They could cover house insurance and life insurance and boat insurance and motorcycle insurance. They just couldn't cover health insurance for all of what is covered under the plan, which is basically all medically necessary care.
Well, in these other countries, whether you like it or not, they exist in those countries often to allow affluent people to get the head of the line. And I personally don't necessarily think that's fair. There are some realities that exist in the world, and that's kind of one of them. Garrett, what are your thoughts about that?
Well, I'd like to add something. I've been wading through the current single payer bill that will be introduced soon in this what is it, 118th Congress, and what will happen to the workers in Humana, for example, when we get our single payer plan. There will be in the act is a provision for temporary worker assistance for up to 5 years, which comes from at least 1% of the budget of the Medicare for All budget will go for temporary up to 5 years for helping those people to get on to get another job. But there would be a necessity for a lot of the computer and other administrative expertise that these insurance companies have, so they could work for the fund. But it's just that there would not be any extraordinary income.
Well, let me ask you this question. It's been estimated that of the approximate $3.6 trillion that we spend on healthcare, that approximately a third of that money is wasted. For example, paying stockholders, advertising, pharmacy benefit managers, et cetera, et cetera. If we took that money and instead of spending it for things that are not really health care and put it into the trust fund, would there be enough money to pay for the system without increasing taxes, and would the system support itself?
Well, there would be sufficient money to, expand the coverage and cover everybody and improve the coverage for everybody. But the money that people and the government and employers now pay into premiums and copays and deductibles, that money has to be replaced in some way. So that there would be more public money that would go into it. I think right now we have about 65% of the money in our healthcare system is already public money, because we're paying for Medicaid and we're paying for Medicare and we're paying for the health plans for public employees, city and state and county and federal. So, but we do have to increase the taxes. And it would be important, single payer says it has to be progressive. For instance, one of the things in the Congressman John Conyers bill, which was the long-standing single payer bill for a long time that was in the Congress, said that there would be 0.25% excise tax levied on stock and bond transactions, which is a clever thing to do, because that's the area where the people who have the ability to do those transactions have the ability to pay a tiny thing. So it'll be a progressive tax, and everybody, all of the working people in the country will pay less in taxes than they pay now for premiums, copays, and deductibles, et cetera, which is just absolutely huge.
Well, as you know, there's a big controversy going on in Congress right now about the budget bill, and the concept is that we have to increase the amount of money we can borrow, or there will be an economic catastrophe. So if you talk to someone, how are we going to increase taxes under the current situation and have single payer health care? A lot of people are going to say we'll go bankrupt.
Well, but you see, what people won't be paying now, employers now pay a huge amount. I think the average, it may be 16,000, something like that. It's huge to purchase the insurance. That they don't pay. They get to keep that. So there's all of this money that doesn't get paid in premiums, co-pays, et cetera. And that a portion of that we will retain in taxes in some way that is fair within the country. So it's not like an extra money on top of what we're paying now. It's like a small increase in taxes in return for a huge, huge lifting of the payment burden that we're now paying.
I think this is a really important issue, and it's going to be a real challenge to get this understood by the American public. Garrett, what's your thoughts about this?
Well, I just endorse and underline what Kay just said. I mean, if you put the two pieces of money side by side, and early on they're saying that there may be some increase in taxes, but as soon as it levels out, there'll be money in your pocket, compared to what you're paying now. And not only is there that financial difference, you get health care. We think about we would become a healthy nation. People, they would be able, all of the benefits are, for example, you don't have to shop for, quote, health benefits when you're looking for a new job, when you're graduating from school. You choose the career that suits you, and you're not prevented from having it, or if you lose your job, you lose your insurance. All of that stuff goes away, and you've got that, and the slight increase early on and of tax is well worth the benefits that you get. But by and large, it's going to, as Jean pointed out, the amount that you're paying in taxes is much less than what you're wasting on bad insurance.
Yes, I absolutely agree. The problem with that is that the legislators mostly have really good health insurance. John McCain was operated on at the Naval Medical Center in Bethesda. Ronald Reagan had his colon cancer removed. I don't know if you all remember that. There was a member of the Naval Reserve here from Louisville who, a good friend of mine named John Spratt, was asked to write a position paper on his medical treatment at Bethesda. Trump got treated at the National Military Hospital when he had COVID. So these people, the problem. You're absolutely right, Garrett. But the people who need this the most are the least influential ones. And I don't know how to do this, but getting that information out and instilling this into the brains of so many of these people. I mean, just think about Kentucky. I mean, it is astonishing to me. I've asked Jean about this a number of times, why people in rural Kentucky who elect legislators who produce policies who are against their health and economic self-interest for a whole lot of ideological reasons. So we got some real issues here. Let me just change topic for just a little bit. Maybe I could ask the two of you if you could just kind of enumerate. I think you did a little bit of that before. Everything that would be covered in the at least your view of a single payer, the Medicare for all, hospital doctors. Does this include long-term care, mental health, preventive? Can you all just kind of go through the list of what's covered, vision, dental, and what, and maybe kind of what wouldn't be covered, like getting your nose fixed or your breast implant done or whatever else that was going on.
Well, I'll start, and Kay can supplement what I leave out, because I've just been over this in the new bill, and it's all there. And people are attracted to so-called Medicare Advantage, which is actually a Medicare disadvantage, but because it gives hearing and glasses and dental things that are not basically covered by Medicare, for example, but those are included in the new bill, as well as long-term care.
How about medical supply costs? Medical supply costs, if you had to get crutches.
Yes. Specifically included medications, all necessary medications, including medical devices and of that nature, and hearing aids and glasses. It's all included.
Now, how about this insane law that we have now that prevents Medicare from negotiating with the drug companies? Is that, I know there's somewhere
goes away.
Things that goes away.
Okay. Let me ask you a question now. If we go to single payer health care, then we won't have industry like the automobile industry, etc., having to pay for health care. Won't that increase their profits and increase their ability to compete around the world?
Well, I think that's true, that there is an economic advantage to having the healthcare covered. I know that in Canada, the GM and Ford and the big three, back then it was Chrysler, have a statement that they are supportive of the healthcare system in Canada as it is, because it gives them an economic advantage. They're not paying the big bill for healthcare that's paid by the auto companies in the United States. So, it will not damage our economic status. It will instead improve it within the ability to produce things within this country, because the bill for healthcare will be less for those employers.
Now, we've had a fellow named Don Henderson on, who is some distant relative of Jane's a month or 2 or 3 ago.
Yes, he's a first cousin once.
Okay.
In other words, his mother and I are first cousins.
Okay. Well, I want to get into the family history. One of the things he said in his program, which I was really pleased to hear and a little surprised, was, and he's a very experienced. He's got a doctorate of health management. Is that correct?
That's correct.
And he having managed hospitals and healthcare systems, and just moved down into Florida with a new job. That he eventually, he says that eventually the system is going to collapse, and eventually we will get to what we're talking about today. I mean, I don't think I had a chance to ask him. We're having it back sometime in June or July, maybe, how long that might take. But this is an administrator who, I think, in many ways, one of the problems we've got in healthcare today is that we've got 10 administrators for every practicing physician, which means a lot of these people are sucking money out of the system for a whole lot of reasons that it doesn't have anything to do with healthcare.
Well, I would like y'all's opinion on one of the things that really bothering me and going at almost an exponential rate is that the privatization of Medicare. We now have an Advantage Medicare program at 50% of all Medicare patients. In the last few months, we've had large companies, United Healthcare and CVS, accumulated large groups of people. CVS, for example, owns Aetna. They own Signify Health. They just purchased several large groups of physicians, and they're assuming they're going to consolidate all these people, and other insurance companies are doing the same thing. It seems to me that the for-profit industry is expanding and headed toward a monopoly. And this is going rapidly, and both parties in Washington are allowing this to happen. What's your opinion about this, and what should be done about it?
Let me say something quickly, and then I want Kay to pick it up because she's been right on the front lines working against it. It's horrible. And I think it could be something that will push us to single payer sooner, because we've got to oppose this movement. It's going to destroy the profession. Your go, Kay.
Well, this privatization of Medicare is just atrocious, and there's a new program that's been around only, well, it was under another name a year or two ago, started under Trump, but it's continued under the current administration, it's called now ACO REACH, and it has a strange name, Realizing Equity and Community Health, and it's doing anything but bringing
it's the most hypocritical acronym I've ever seen. Go ahead, Kay, sorry.
It is indeed. Instead of bringing us equity, it is bringing those who chose to stay in traditional Medicare, not the private plans, are being put without their consent into these plans that are run by venture capital, private equity, and large insurance companies. And they up the profit of those companies. Within Medicare Advantage, the companies are taking about 15% in profit and in administrative costs. Within the new REACH program, they get about 25% to start with, and it can go up as much as 40%. And what it does to the patient is that it reverses the incentive, because the providers are paid on a capitated basis. They get so much for that patient per month, and they get that money regardless of if they do anything. So if they don't give care that month, they get to keep all of the money. So the incentive for giving care reverses to where there is a profit incentive not to give care. And that is growing across the country. There are 2.5 million people in it. We have them in Kentucky. We have Oak Street. There are 2, and maybe a third one opening here in Louisville. We have Illumed that's opening in Pikeville and they have it in Pikeville and in Hazard. We have Village MD that is in Murray, Kentucky. And these are in that ACO REACH program that is profiteering like crazy off of our Medicare. And that's just that piece of it. The bigger piece of profit is the Medicare Advantage, which is designed to force people into it, because I get so upset when they say, oh, Medicare Advantage is so popular. More and more people are choosing it. Duh. Most people are on limited, modest, fixed incomes. And Medicare Advantage is made available for a lower per month price. That's why they go to it, because if you're in traditional Medicare and then you purchase a Medigap plan, it's a bit expensive. So those people who, which is most of our seniors, because our pension system is collapsing too. Most of our seniors don't have lots and lots of money laying around. So that's why they go into the Medicare Advantage, and we have to fix it by removing Medicare Advantage, removing this ACO REACH, putting all of us into an improved Medicare that takes away the copays, the deductibles, the premiums, adds the additional benefits, the long-term care, the eyeglasses, the mental health care, et cetera, and really gives us a system that works. And if we don't do it, we're getting robbed blind. You know, the Biden administration just announced that there were, it's maybe 10 to 20 billion a year that they're getting in overpayments to these Medicare Advantage. Well, they put out a proposal that they would ask for some of that money back. And before it could get enacted, they ratcheted it down to it'll take place over 3 years, won't ask for all of the money, et cetera. We're being robbed blind by the insurance industry. So much so that Humana now, they're saying they're leaving the employment-based market because they can make more money, you know, in Medicare Advantage. And they're also, Humana's in ACO REACH in many of the states in the South. So we have to do something or we're not going to have Medicare left. You know, Liz Fowler, who heads up the Innovation Center at Medicare, says they're going to have everybody in these kinds of plans, these value-based plans, which is another whole issue, by 2030. So they're headed for the complete privatization of Medicare, which is really destroying the program as our country's most beloved program and the one we want to use to.
Yeah, what's really worrisome about that is a lot of this seems to be originating in the Medicare bureaucrucy, which I think is crazy. I was down in Arizona in February with an old friend of mine from way back when, and they were telling us a story of, I don't remember all the details, it's not really relevant, but there was a person who was in one of these ACO REACH programs who needed to get seen in an emergency room and needed to get hospitalized. And I mean, they couldn't get that done. I'm not trying to, I don't remember if this was I think it was somewhere up in Wisconsin. And when they finally ended up in the hospital with their care, they were they had complications, and you're absolutely right about that. We've got some real serious issues. Now, I want to warn you both. We're down, I think, to 4 minutes, so we're getting down to the end of the lollipop here. Gene's going to ask. He's got a question, and then I'd like you to both to see if you'd like to make a couple of closing statements, and we may have to end this program. I'm thinking we might want to do another one of these because there's a whole lot we still haven't talked about.
I just want to point out one thing that most people don't know. 70% of the nursing homes in this country are owned by equity companies. So if you have a relative in a nursing home, probably 10 or 15% of the money you pay for that care is going to the equity company. Now, I do have one more question is who would pay for medical school under this type of system?
And we're gonna have to talk fast because the clock. is
Yeah,
running.
Gene, I'm glad you asked the question because I have the answer, and you had asked it before. It's specifically in the budget for the new Healthcare Act. Professional education expenditure sufficient to provide for the amount of professional education required to meet the covered health services. And also, just quickly, you would like to understand that the Secretary, Health and Human Services Secretary, is to provide each regional office with an allotment of funds that the Secretary determines appropriate for carrying the act out in that region. So it becomes administrated on a regional basis.
All right, down to 2 minutes. Kay, quick final comment. And if we've
Well-
got time, we'll let Garrett have one as well, but the clock is running.
I just think it's important for us to stay with a real single payer plan that removes the profits, that's national in scope, and not to say, oh, well, look at the Congress, it's too hard to do that, so let's do a different plan. This is the plan that we need to do, and we have to raise the demand to make it happen.
I agree. Garrett, last minute comment.
It's a moral imperative, and we got rid of slavery. We got women to vote. We can do this.
Well, thank you both very much. It's been an excellent program. Mark's going to take us out.
Kay, Garrett, always a pleasure to be in the same room, even if you guys are coming to us on Zoom. It's great seeing you guys, and hopefully we can get out on the streets outdoors and see each other in person again. Single Payer Radio, again, is a project of Kentuckians for Single Payer Healthcare. If you'd like more info, you can go to kyhealthcare.org, kyhealthcare.org. You can follow the group on Facebook, Instagram. Let me see. We do we broadcast Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. Another great show, guys, for Single Payer Radio. This is Mark McKinley. Have a good week. Thanks for listening.